Two good cartilage operations, same outcomes, so how do you choose? OVO baby, Iceman season if you know you know. Cartilage repair isn't about innovation, it's about judgment, restraint and patient selection, and that's exactly what this week's paper helps us think through. It's the Sunday paper roundup where I read the literature so you don't have to. This is a recent Kester paper comparing single-stage minced cartilage implantation with two-stage autologous chondrocyte implantation or ACI. It sits squarely in the cartilage restoration space. This was a matched pair analysis from a high-volume centre comparing 25 ACI patients with 25 minced cartilage patients, matched for age, defect size and location, mostly patellofemoral lesions, average size around 3 to 4 centimetres squared, with outcomes at 2 years. They focused on pain and function and where the improvements were clinically meaningful. The results? Well, both groups improved. At 2 years, pain and functional outcomes were comparable with similar reoperation rates. So in the short term, both procedures work. To understand why this matters, you need the wider context. Microfracture has historically been widely used because it's simple and accessible and cheap, but we now know its durability is limited, especially beyond small defects. That's why I don't perform microfracture anymore, and why restorative options like ACI and now single-stage techniques like minced cartilage implantation exist. Now, would it really be a Sunday paper roundup if we didn't critically appraise it and look at the strengths and weaknesses? The strengths are that it's a rare head-to-head comparison of two really good restorative cartilage techniques, careful matching for defect size and location, same surgeon and rehab protocol that reduces technical variability, and the emphasis was on clinically meaningful outcomes and not just p-values. The limitations, well, it wasn't randomized, the small numbers, only short-term follow-up, and no long-term durability data, and many patients had concomitant procedures, which reflects real-world practice but complicates interpretation. And there were PROMs only, there was no imaging or return to sport outcomes. So how does this translate into practice? Well, AC-MACI remains the reference option for larger isolated cartilage defects when you want the most established evidence base, accepting cost, access issue and that it's 2 operations, but minced cartilage is a viable single-stage alternative, particularly when you want to avoid 2 surgeries or where ACI isn't accessible. And importantly, small lesions demand restraint, not escalation by default. As always, we finish the Sunday paper roundup with a verdict. Should you ignore it, be aware of it, really consider it, or go right ahead and change your practice? And my verdict, you should really consider it. Not because it replaces ACI, but because it reinforces that expert cartilage surgery is bespoke surgery, choosing the right intervention for the right patient and lesion. And for true knee preservation, we must also address alignment, stability, and meniscal integrity first. Follow for more evidence-based knee surgery breakdowns. I'll keep breaking down the literature as it lands.